Welcome to the 2025 Protocol Update presentation from Montgomery County Fire and Rescue. I will cover some of the key changes and additions for this year's protocols. Here are the topics we will be covering in this video. You may ask, don't I already do a protocol update for MEMS? Of course, we still have a statewide update, but this video is here to prepare you for and reinforce some of the major changes coming this year and provide details specific to Montgomery County. The video will be broken down into some very brief coverage of small but noteworthy changes, then have some in-depth looks at new protocols and major changes to existing ones, and finish with a review of some changes that are either fairly significant but uncommonly used or very common but minor changes. Here are our quick hit changes. First, the time for the administration of calcium chloride and TXA has been changed to 3 to 5 minutes. This is due to the fact that the previous concerns about time of administration were not evidence-based, and delivering these medications faster to critically ill or injured patients is likely beneficial. Our IV pumps can administer these medications diluted in 100 mLs of D5 in 6 minutes. This is an acceptable time frame, and MIMS agrees with this method of delivery. Next, consult is now required for cardioversion of narrow complex tachycardias in pediatric patients. This change is intended to make the treatment consistent with wide complex tachycardias in pediatric patients. Finally, droperidol has had the intramuscular route added for the treatment of nausea and vomiting, making administration simpler if IV access is not readily available. A consult requirement for the use of diphenhydramine or Benadryl to treat dystonic reactions due to droperidol administration has been removed. The first new protocol that we'll do a deep dive into is the Hypertensive Disorders of Pregnancy Protocol. This protocol is important because hypertensive disorders of pregnancy, or HDPs, such as preeclampsia, eclampsia, and HELLP syndrome, have high maternal and fetal morbidity and mortality rates. And they are often underrecognized and left untreated in many medical environments. Specifically to EMS, these disorders were recognized as a primary impression in only about 1% of OB-related EMS patients nationwide. This is in comparison to the overall prevalence of preeclampsia, which is thought to be as high as 8%. Pregnant patients who were identified by EMS as presenting with hypertensive disorders were some of the most critical patients, with 53% presenting as high acuity and 70% identified as high acuity using an objective screening tool. Additionally, 70% of maternal deaths related to cardiovascular disease occur postpartum. Treatment of these patients is extremely time sensitive. Beginning blood pressure management within 1 hour of identification of a hypertensive disorder has been shown to have a 72% relative reduction in the risk of maternal morbidity. As will be discussed in more detail shortly, this protocol also outlines the treatment of patients who progress to eclampsia. Magnesium sulfate is the first-line treatment for these patients. Eclamptic seizures are different than classic neurogenic seizures in that they are relatively shorter and self-limiting. Magnesium helps to prevent the reoccurrence of additional seizures. Midazolam is reserved for seizures which do not respond to magnesium. An important note for this protocol is that a major goal of it is to increase the general awareness of these diseases, not just for EMS, but for the receiving facilities. And the patient population it applies to is pregnant patients from 20 weeks gestation to 6 weeks postpartum. This map is a graphical representation of the distribution of HDPs in Maryland. As you can see, while there is certainly an increased prevalence in areas around large population centers like Silver Spring, Prince George's County bordering DC, and Baltimore, there are many rural areas that have some of the highest occurrences of HDPs as well. The initial evaluation and treatment of HDPs is essential to pay attention to. Treating blood pressure outside of pulmonary edema is something new for EMS in Maryland. Balancing the benefits of quick treatment with accurate evaluation of these patients is critical. Blood pressure management can only be initiated after two blood pressure readings, at least 15 minutes apart. One of these readings can come from another licensed healthcare clinician if the patient presents from a medical facility. At least one of these BP measurements also should be a manual reading. Treatment is broken down into moderate and severe groups. The moderately elevated patients are those with a BP of systolic between 140 and 159 or diastolic between 90 and 109. If these patients present with a known history of preeclampsia or signs and symptoms of severe preeclampsia, such as an acute headache, visual changes, right flank pain, or epigastric pain, they should receive 4 grams of magnesium sulfate over 10 minutes. Severe presentations of this disease include both those with an elevated blood pressure and those with eclampsia. Severe blood pressure elevation is defined as a systolic blood pressure greater than 159 or a diastolic blood pressure greater than 109. These patients should receive treatment whether or not they have signs and symptoms. The goal is to safely reduce their blood pressure to an acceptable range, with this goal being systolic blood pressure between 120 and 160 and a diastolic blood pressure between 80 and 110. Labetalol is the new medication for our protocols, which we give to reduce blood pressure. The first dose is 20 milligrams given IV push over 2 minutes, with the same second dose after 10 minutes if the blood pressure is not reduced to the goal range. A third dose of 40 milligrams can be given with consult if the blood pressure goal is not met. If the patient also has signs and symptoms of preeclampsia, give 4 grams of magnesium sulfate over 10 minutes. As discussed previously, if the patient presents with suspected eclamptic seizures, administer 4 grams of magnesium sulfate first and then follow with midazolam if the seizures do not terminate. If following resolution of seizure activity, the patient is severely hypertensive per the above blood pressure ranges, begin treatment with labetalol as well. Since labetalol is a new medication to our formulary, I wanted to provide some background on it. Labetalol is a non-selective beta blocker. This means that it has antagonistic effects on both beta 1 and beta 2 adrenergic receptor sites. Beta 1 sites are located in cardiac cells, so a blockade of them results in a reduction of heart rate and contractility. Beta 2 sites are located in the lungs, so a blockade results in the prevention of bronchial dilation. The beta 2 effects are why labetalol should be used with great caution in patients with a history of obstructive lung disease. Labetalol also has alpha 1 adrenergic receptor antagonistic effects. Alpha 1 receptors are located in cardiac cells as well as vascular tissue. Blockage of the cardiac cells results in a reduction of heart rate, while the vascular effects result in a reduction of vasoconstriction. Labetalol is commonly used for the control of hypertension during pregnancy, as it does not have fetal developmental side effects that other antihypertensives can cause, and it does not produce reduced fetal heart rates either. This slide describes some of the treatment and transport considerations for hypertensive pregnant patients. If a pregnant patient presents with respiratory distress and signs of pulmonary edema, they should receive treatments in accordance with the CHF/pulmonary edema protocol. Acute hypertensive heart failure does occur in pregnant patients, and these individuals are best treated with CPAP and nitrates for blood pressure reduction. As described previously, labetalol can have negative impacts on patients with obstructive respiratory pathology. It is contraindicated with active, note that this is not a history of, but active asthma exacerbation, and it should not be used with high degree heart blocks, bradycardia, or acute heart failure. Transport of patients with an HDP who present with signs and symptoms of preeclampsia, such as severe level BP readings or eclampsia, are best managed at perinatal referral centers. They should be transported to one of these unless it is 30 minutes further than the closest ED, which would rarely be the case in Montgomery County. This is a list of nearby perinatal referral centers. There may also be cases where a patient receives their normal prenatal care at a different facility, and transport to these facilities should be considered if patient condition and time allows for transport there. I'll close this portion with a brief reminder that Suburban Hospital does not have OB or labor and delivery services, so transport there of pregnant patients with an HDP should almost never be considered. Now we're going to switch gears and talk about some of the changes to the septic shock treatment protocol. Previously, large volumes of fluid administration were required prior to initiating a vasopressor infusion for these patients, even in the setting of profound shock, despite the fact that even gravity infusions of this volume would take significant periods of time to be delivered and have not had clear benefits in the literature. The sepsis protocol has been modified to allow for the earlier use of vasopressors in patients with profound hypotension and altered mental status. It also allows vasopressor use with fluid-sensitive patients after limited fluid resuscitation who have severe hypotension. For non-fluid sensitive patients with less severe hypotension, the treatment remains generally unchanged. Here are some of the specifics of the protocol. For non-fluid sensitive patients, they should receive a starting bolus of 2 liters of IV fluids. If they remain hypotensive, they should receive additional fluids up to a total of 30 milliliters per kilogram of IV fluids. Fluid-sensitive patients should receive an initial bolus of 250 mLs of IV fluids, and if there are no signs of pulmonary edema or respiratory distress following this, they should receive an additional 250 milliliters of fluid up to a maximum of 500 milliliters of fluid. Fluid sensitive is defined by the protocol as patients with a history of CHF, pulmonary edema, or end-stage renal disease. Norepinephrine is our vasopressor of choice in Montgomery County for the treatment of septic shock. With patients who present with a SBP under 70 or a MAP under 50 and altered mental status, norepinephrine should be started at 10 micrograms per minute at the same time as IV fluids. A systolic blood pressure of 90 to 140 or a MAP of 65 to 90 is the target goal for these patients, with norepinephrine being titrated upward to meet this. Non-fluid sensitive patients should receive fluids to the maximum of 30 milliliters per kilogram, and if their systolic blood pressure is still under 90, then receive norepinephrine. Fluid-sensitive patients should receive the initial bolus of 250 milliliters, and if they develop any signs of respiratory difficulty due to fluid overload, still have a systolic blood pressure under 90, then receive norepinephrine. If they do not develop respiratory distress, they can receive the second 250 milliliter fluid bolus, and if still hypotensive, then initiate norepinephrine. Good question to cover at this point is the matter of what to do when only one IV pump is available and a patient needs both IV fluids and norepinephrine. First, I will recommend that whenever transporting a patient who requires a titratable vasoactive infusion like norepinephrine, it may be a good practice to obtain a second ALS clinician to help with their management. If only one IV pump is truly available, then the norepinephrine infusion should be given on the IV pump while IV fluids can be infused via gravity. The second new treatment protocol for this year is the alcohol withdrawal protocol. This protocol was developed as a treatment of alcohol withdrawal is both critical and sometimes missed in pre-hospital medicine. Severe alcohol withdrawal is a life-threatening condition. It generally occurs around 48 to 72 hours after cessation of alcohol ingestion. Even in mild to moderate cases of alcohol withdrawal with a history of severe episodes may be admitted to the ICU for close monitoring. The cause of alcohol withdrawal symptoms is related to the chronic ingestion of a sedative, in this case ethanol, which causes the overproduction of opposing excitatory chemicals, in this case glutamate. With the abrupt cessation of ethanol ingestion, the overproduction and release of glutamate continues. This results in overstimulation of excitatory neuroreceptors, which can cause sweating, tremors, seizures, hallucination, coma, and even death. This slide addresses the evaluation of patients for possible alcohol withdrawal. The protocol is limited to patients aged 13 and older. It utilizes the Brief Alcohol Withdrawal Scale, or BAWS. This scale evaluates the presence and severity of several symptoms, which are tremors, sweating, agitation, confusion/orientation, and hallucinations. The total number from these scores are added together. A score under 3 represents mild withdrawal. A score of 3 or higher indicates moderate to severe withdrawal. The treatment of withdrawal symptoms is outlined on this slide. Patients with mild withdrawal symptoms should receive treatment for nausea with ondansetron or droperidol and be placed in a position of comfort. Those with moderate to severe withdrawal resulting in a BAWS score of 3 or greater or a known history of severe withdrawal should receive treatment with midazolam. Benzodiazepines, like midazolam, are commonly used for the treatment of withdrawal symptoms since their sedative effects help oppose the excitatory effects of glutamate. The initial dose for midazolam in the protocol is 2 to 2.5 milligrams IV push. This dosing range is listed like this as some jurisdictions carry 2 milligram vials of midazolam. Generally, with our concentrations of midazolam, we would administer 2.5 milligram doses. This dose can be repeated twice to a maximum of 6 to 7.5 milligrams total. If no IV is available, 5 milligrams midazolam can be given either intranasal or intramuscular. The goal of all treatment is a reduction of tremors, sweating, agitation, and anxiety. Any doses beyond the 6 to 7.5 milligrams IV or the first dose via IN/IM require consult. These patients should also be monitored with an ECG and have a 12-lead performed. In this next section, I will cover some topics that require less detail than the last 3 topics, but are still significant changes or affect common treatments. The first topic is the introduction of the distal femur as an IO insertion site. This site can be used both for pediatric patients under 13 and neonatal patients under 3 kilograms. This site was added as it has a high success rate and may be easier to place than the distal tibia or proximal humeral IO in children. In smaller children, the tibial sites may be more difficult to locate due to the lack of the tibial tuberosity, or the tibia may be relatively small. The IO infusion protocol also has had this chart added, which outlines the preference for placement sites by age. Next is the increased maximum dose of dexamethasone. This has been increased to 15 milligrams for both adult and pediatric patients. This is the standard max dose in most emergency medicine settings and is generally more effective than the previous maximum dose of 10 milligrams. And while this is a relatively simple change, please keep in mind that with our current concentration of dexamethasone, this requires using 2 10 milligram and 1 milliliter vials and drawing up 1.5 milliliters of medication when administering it. The next 2 slides will cover some of the changes that were made to what previously was known as the drowning protocol, which is now the submersion protocol. First, I will cover the portion of the protocol that relates to patients who were submerged in water and are not in cardiac arrest. The first step is to determine the severity of the submersion. The criteria are listed here, but look out for refractory hypoxia, changes in level of consciousness, signs of pulmonary edema, and respiratory failure. Treatment is based on the severity of the submersion and possible lung injury. Mild submersion only requires supplemental oxygen in the treatment of possible bronchospasm. Moderate submersion requires more support with positive pressure ventilation via a bag valve mask or CPAP, and consideration of advanced airway. Intubation is the preferred method of advanced airway management in submersion patients, as it helps better protect the airway from retained fluids, allows for better suctioning, and is associated with improved outcomes in severe injury. Related to that, severe cases of submersion injury should have positive pressure ventilation if they are conscious, and advanced airway management if unconscious and appropriate. They also need treatment for any hypotension that may occur. The transport destination of these patients is important to consider. Moderate to severe submersion involves significant traumatic injury to the lungs and requires transport to either a ECMO CPR capable center, otherwise known as an eCPR center, or a trauma center. Pediatric refusals of submersion patients by their parents or guardians are inherently high risk, as the signs of submersion injury may not present until significant time after the submersion. Consultation with a pediatric base station is required before completing the refusal. This slide covers the treatment and transport of submersion patients in cardiac arrest. Important definitions at the beginning is the difference between warm water and cold water submersion. Warm water refers to water temperature above 43 degrees Fahrenheit. Most outdoor bodies of water in Maryland will be considered warm water from late March to November. Cold water is water below 43 degrees Fahrenheit, and outside bodies of water in Maryland will likely be cold water from December to early March. The initial actions should be the same for all patients, with resuscitation and early intubation. Ventilation should always use PEEP in these patients. Placement of an OG or NG tube in these patients is also very important. During the initial resuscitation, the water temperature and time of submersion should be obtained. This will guide the following steps. For warm water patients, the time of submersion is broken down into submersion under or over 30 minutes. For submersion under 30 minutes, patients should receive a full resuscitation with 15 2-minute cycles of CPR. After this resuscitation, if the patient is in a systole or VFib, VTAC, or PEA with an end tidal of under 15, you may terminate resuscitation. If the submersion time is over 30 minutes, patient has an initial rhythm of asystole, you should proceed to the pronouncement of death. Otherwise, with other rhythms, initiate resuscitation and follow the previous direction with 15 2-minute cycles of CPR, and then reevaluate for any termination of resuscitation. Cold water is divided into submersion under 90 minutes and over 90 minutes. For submersion under 90 minutes, resuscitation should be initiated and early transport to a eCPR or ECMO CPR capable facility should be considered. A consultation, please note this is not a notification, is required for these patients to determine the intervals for defibrillation and drug administration. For submersion over 90 minutes, the patient's cardiac rhythm should be determined. If they are in asystole, then pronouncement of death should be performed. If they present with any other rhythm, resuscitate and consider transport to an eCPR center. For patients under 18 years old, refer to the pediatric cardiac arrest protocol. If the patient's submersion time is unknown, then provide resuscitation and follow the medical TOR protocol for TOR decision making. A related change to some of the submersion transport destination changes is the alteration of transport and timing for patients with severe cold exposure related emergencies or those in cardiac arrest secondary to hypothermia. These patients should also be transported to an ECPR capable facility if it is within 30 minutes. If not, they should be transported to the closest appropriate facility. I want to take this time to discuss the decision to transport to an ECPR capable facility. Maryland Protocol is currently ahead of the capabilities of most ECMO centers when it comes to this treatment. There is still a small subset of patients who would clearly benefit from ECPR. However, this is still usually a slim chance for survivability in the submersion or cold exposure scenarios. And the longer they go without ECMO, the worse outcomes there generally are. Washington Hospital Center is the closest ECPR center to the majority of Montgomery County. But at the time of this recording, they have advised that they are not prepared to perform ECPR routinely. The current best practice is to evaluate each patient who may be considered for ECPR on a case-by-case basis, weigh the benefits of transport to an ECPR facility with the downsides of an extended transport time. As noted in the protocols, there is consideration for helicopter utilization to reach an ECPR facility. The benefits of this will rarely outweigh the extended time to helicopter arrival and transfer, if aviation is not already on the scene when patient contact is made, and the overall risks of flight utilization. Pediatric patients may sometimes justify the extended transport times to reach an ECPR facility. The best backup options for adult patients to an ECPR facility may be transport them to a trauma center. This is a good point to again highlight the lung submersion injuries are considered traumatic in nature. So regardless of age, these patients should generally be transported to an appropriate trauma center. This slide will cover the other new medication for this year's protocols. This medication is cefazolin, more commonly known by its brand name, Vancef. It is a broad-spectrum antibiotic used for the treatment or prophylaxis of infections related to trauma or other invasive surgeries. It has been added to the protocol because patients with major trauma involving open injuries are at high risk for systemic infections and sepsis, which can greatly complicate their recovery and cause increased morbidity and mortality. The indication for cefazolin are open fractures, amputations, or mangled extremities. Cefazolin can be given to patients of any age, but those under 1 year require consult for administration in their dosing. It is important to note that the stabilization or transport of a patient should not be delayed to administer cefazolin. The following video demonstrates how to set up the infusion of cefazolin using the duplex bag system Montgomery County has obtained. As you've probably noticed throughout this presentation, there are multiple resources in the EMIHS reference app that can assist with some of the new materials and changes in the protocol. It also includes a large amount of other information and tools, as well as CPGs and other reference materials. Please feel free to reach out to me anytime for more information on protocols or anything else. Thanks for your attention and have a great day.